Welcome to the Derm Vet podcast, where pet skin is always in. I'm Dr. Ashley Bourgeois, board-certified veterinary dermatologist, skin nerd, and your go-to guide for everything itchy, smelly, and inflamed. I'm here to take the itch out of your day and make derm more fun than frustrating. Grab your microscope and let's focus in. Welcome to another episode of the Derm Vet podcast. Man, you guys have been waiting. I have been waiting to have this guest on the podcast. We are having Dr. Fred Wininger on the podcast, boarded neurologist, just opened a beautiful facility in St. Louis, Missouri called the Animal Neurology Center. Dr. Fred Wininger, thank you so much for giving up your time to be on the Derm Vet podcast.
It's my pleasure. I've been waiting for a long time for this. I'm expecting to learn a lot.
Learn. Oh, gosh. Okay. Well, it's been a long time in the making. You've kind of had a couple things going on as you open this beautiful new facility, which I'm hoping to come visit myself this summer. But I've only heard wonderful things. And sneak peek into real life situation, you have a resident currently doing surgery on a back dog.
That's right. I often say that neurologists are not specialists. We are emergency doctors that do specialty medicine. So it's that's what makes neurologists want to do it, is the excitement of neurosurgical emergencies and things like that. So yeah, we're busy.
It's a little bit different. So I like to say we always make it to 5 when we go home, and rarely does anything die in dermatology.
Yeah.
So
I think you know this, but my dad is a human dermatologist.
I do know that.
So I feel that. I feel that.
We like it's funny because clients will bring in their pet and they're like, "You're going to be horrified." And I'm like, it takes a lot to get me horrified. It'll be like a little pustule. I'm like, no, It has to be pretty bad for me to be grossed out. And I'm still probably not grossed out. I'm probably excited like you are right now.
Sight-wise and smell-wise, right?
Yes. Yeah, they're like, it's really bad. And I'm like, I don't really smell anything. That's fine. Well, I'm really excited to have you on. Derm can cross over with a lot of different specialties. And people may say like, well, neuro and derm, how? And really a lot of it's going to be like internal, right? Ear disease, things like that. But we're going to spend our time together this week talking about dogs and some of the overlap that we have. And then we'll bridge a little bit into cats next week. So let's just start out. A lot of the overlap between derm and neuro is the peripheral vestibular signs, right? It's kind of confusing. It's nice to image them, but GPs can't always do that. So can you walk me through differentiating a case with your neurologic exam? They come into you that you're going to say, okay, this is peripheral vestibular. Maybe it is something like an otitis media.
Sure. It's a huge topic.
Yeah.
I think vestibular disease is one of the things that veterinarians feel very comfortable saying, yeah, that dog looks like it has vestibular syndrome, and then they feel like they get stuck, So when I talk to a client, the first thing I say is your dog has a problem with balance. And I try to avoid using the word vestibular right off the bat because they automatically go to the Google search of the senior dog geriatric vestibular syndrome, right? So I start with that. And the way you know that a dog has vestibular syndrome, of course, is that they have a head tilt. They tend to have this ataxia, which is kind of this leaning, listing, falling, rolling, not circling. From there, they often have nystagmus. And those are things that are going to be often universal to the vestibular patient. And then what I'll tell the owner is the next step is to try to figure out, is this a problem in the ear where all that information is received, or is it a problem in the brainstem where all that information is processed? And the reason why that's such an important distinction is a problem in the ear is going to have not only a very different differentialist, but also a very different prognosis outcome than compared to a brainstem problem. So how are we going to distinguish peripheral versus central vestibular syndrome? Well, there's a bunch of different ways. The ones that I wanted to focus on with you, Ashley, are two. One of them is going to be if you have cranial nerve 7 abnormalities, so facial weakness, or if you see a Horner syndrome, which would be a loss of sympathetic tone to the face, like a myotic pupil or something like that, that's going to be much more suggestive of a peripheral presentation than it's going to be of a central presentation. It's not perfect. There are cases of central disease that will have that, but usually it's going to be peripheral. And then the other thing that I really harp on is look for proprioceptive deficits. And this can be difficult. The dog's not always able to stand up straight. They're leaning they're falling, they have extensor tone on one side of their body. But if you see a dog that's knuckling, particularly on one side of the body, that's going to be much more indicative of a central problem. And that should be a big, like, red flag, something's going on in the brainstem. There's a couple other things that can help differentiate peripheral from central vestibular disease, namely the presence of a vertical nystagmus. If you see a nystagmus that's going up and down, or if you see a nystagmus that's really, really slow, that's going to be concerning for central disease as well.
And I like how you break it down into simple things, right? Because I'll be honest, when I talk I'd listen to you talk about neuro. I'm like, you talk about cranial nerves. I'm like, oh God, I hardly remember those anymore. But there are some key things that you brought up. And why I think that's important is, again, not everybody can just send a dog in MRI that second, right? And just really kind of dig deeper. But I've been referred cases and really they're like, oh, I think it's derm because they have an ear infection. And I think I've sent you a video of a case and I'm like, I don't think this is me. Like, it was like goose stepping and doing all these crazy things. I'm like, listen, it has a malassezia otitis, but that is not the cause of the issue going on. So you can certainly have, red herrings. Like, yeah, they have an ear infection, but that's not causing all of these neuroscience that don't make sense for the typical peripheral vestibular dog that, you would see and diagnose.
Absolutely. Like, Ashley, as you know, one of my goals from an education standpoint is to break down these concerns about neurophobia. When people get a neurologic case, all of a sudden their anxiety level starts to rise a little bit because it uses this unfamiliar vernacular, words like ataxia and paresis that people don't feel comfortable with. It's stuff that they don't see every day. And so if we can kind of simplify this into just some if this, then that type scenarios, it'll make the generalist feel much more comfortable tackling these cases. And specifically when it comes to the vestibular syndrome, there is a lot of opportunity for the generalist to deal with these cases. I mean, if you can break it down between peripheral and central disease, you're literally talking about, do I need to keep this case or do I need to refer this case? Because the vast majority of peripheral vestibular syndromes should be managed in the general practice, and the vast majority of central ones should be in the specialist's hands.
And when you talk about peripheral vestibular and, a lot of these being able to be, and I'm, though derm is very different, I always say a general practitioner can be a great dermatologist. There's simple things that you can do. The reality is we love our specialties. We cannot see every patient that's out there. Like, we really are both passionate about general practitioners being able to implement simple things to be more successful at our prospective specialties. Besides otitis media and then like the old dog geriatric, like vestibular, what other things do you consider in that peripheral vestibular category that a GP might manage?
Absolutely. When I think about neurolocalization, so let's say let me take a step back for a second, Ashley. When you think about the vestibular syndrome, its primary function is going to be to know where your head is relative to gravity and relative to really fast movement. I mean, when we were coming out of the primordial ooze and we needed to know how to stand and walk, we needed a very primitive system to fight the universal truth that is gravity. And so that's why this emerged. And it's actually like really interesting. You have these little gyroscopes and accelerometers in your ears that pick up on things, and then they send messages into the brainstem that say, okay, now do something with this. So that said, something's broken inside your inner ear or the nerve that transmits that data into the brainstem. That's what peripheral vestibular syndrome is. And so with any neurolocalization, it's no different than anemia or azotemia or some other blood chemistry change. You have to go through your vitamin D or your DACVIM list, right? So let's do that with peripheral vestibular syndrome. So degenerative diseases, I guess you could consider old dog vestibular syndrome in there, but not very common. Anomalous diseases, not very common. Metabolic syndromes that affect the vestibular system, that should raise some warning bells. Hypothyroidism, so thyroid function is essential, and we see definitely a significant number of hypothyroid dogs that present for peripheral vestibular syndrome. So make sure to test for that. What's next? Neoplastic. So not common, but possible. And nutritional sure, you always want to rule out the thiamine deficiency, but it's not super common. Infectious inflammatory, pretty common, especially in the spring in the Midwest. So rickettsial diseases can cause it out, not just otitis. Don't always think about otitis. Think about vasculitis. Think about other infectious diseases that can hit that area. Um, Trauma or where else am I at? I'm infectious, and iatrogenic. So don't forget about some of the antimicrobials that can cause vestibular syndrome as well. So some of the aminoglycosides, or if you shove a bunch of chlorhexidine down the ear, you can start seeing some vestibular syndromes. And then trauma is not super common, but that could happen as well. So you could see that there's a lot of places where a generalist would say, "Oh, that's my area. I got that."
Yeah. What's the history, right? Like, how old's the patient? Have we recently treated them with some sort of ear medication because they had an otitis, but it seemed to be just a day or two after we started something like an amikacin drop, a gentamicin drop, things like that. I
Sure.
did get asked one particular question. I did ask kind of people in the GP world any questions they'd have, and someone asked about idiopathic vestibular disease in young dogs. Does that entity exist? They were curious your thoughts on that.
Yeah, I'm not really aware of a precedent for that. I can't say I've ever seen that. I think if you see it in a young dog, your brain should instantaneously go to otitis.
Yeah.
And I'm sure you share this with your people, but I feel obligated to share it as well. The absence of external otitis has nothing to do with this. You know, it's really important to recognize that the horizontal and vertical ear canal can look normal. The tympanum can even look normal. And then behind it, they have raging otitis media interna.
Yeah, totally. And I know we're focusing on dogs in particular, and we'll talk about cats next week, but I especially will say I see that with cats, where they just get an otitis media. I get sent them because Neuro's done an MRI and they're like, this cat has bilateral otitis media, and they have never had any history of otitis externa, whether it's an upper respiratory infection that led to that, whatever it is. You're totally right. And that's where imaging, whether it's CT or MRI, can be super helpful in those cases. And listen, most otitis media cases do extremely well. So, we have a pretty good prognosis also to manage that if we can figure out why it's happening, which could be different than some of the cases and things that you are discussing. Um,
Yeah.
so
I wanted to just say one of the things that neurologists are seeing, and I'm actually headed to the American College of Veterinary Internal Medicine forum rather next week, and there's an abstract being presented on this. We're seeing a lot of French bulldogs that present for otitis media interna in the absence of external ear disease, and those guys are kind of important to get in front of for the generalist, and kind of scary because not only do they get that, but they get extension of that ear disease into their skull through, and it can lead to an otogenic extension meningitis. So keep an eye out for those Frenchies. They can definitely present for young dog peripheral vestibular syndrome with raging otitis.
Oh, the Frenchies.
Love them.
Listen, they're frequently seen between our two specialties, that's for sure.
Yeah.
Talking a little bit of a different scope of ear disease, let's talk a little bit about PSOM, because that's the other thing that people are going to think about between our two specialties. Primary secretory otitis media. I'm actually usually sent these by neurologists, right? They MRI them because the problem is they can also have syringomyelia, whether it's both of those things, one or the other. So just go through a 10,000-foot view of what your workup of a standard CAVI is, where you suspect PSOM could be there. What clinical signs are you seeing, and how do you treat them?
Yeah. The cavies are super challenging for the neurologist. They tend to be a little bit of a diagnostic conundrum because what will happen is these dogs will present for a variety of nebulous signs. Often they're presenting for things that are vestibular, but also cranial cervical pain, scoliosis, itching and scratching at the neck. And then you wind up imaging them. And what you see is that they do have that kind of narrowed skull, essentially, what's lovingly now called caudal occipital malformation syndrome more than Chiari malformation syndrome. And then that syringomyelia, and they have PSOM concurrently. And so then the question becomes, well, why are they itching at or scratching at the ears? Is it because they're clinical for their syrinx, or is it because they have the PSOM? And what usually happens is we send them to the dermatologist, not always because we're so confident that the glue ear is causing the clinical signs, but to correct Combs SM or Chiari malformation is just such a challenge. We'd rather take the ears out of the equation before going down that long path because it could be medical, it could be surgical, or it could be a little bit of both.
Yeah, and with that disease process, that is one where sometimes we're a little forgiving of doing videotoscopy and imaging depending on, what the owner can afford, what's available. But that is the disease. If I get a young middle-aged cavy, they're coming in for intense head and neck scratching, which is usually the clinical sign we see. And unless I see bulging eardrums staring right back at me, I'm pretty much saying you have to go to neuro and get imaged first. Because if the eardrums look pretty normal, it's just a waste of time, effort, and money for me to go in, do myringotomies to get nothing out of it because syringomyelia can really mimic this disease. And I'd say a large majority of them that neuro sends us, like you said, kind of have both. And so we have to have a discussion of, yes, we need to do this. Myself and the neurologist are totally on board. I can't 100% guarantee that means they're not going to have any clinical symptoms when we're done because you kind of have two reasons that can really cause that. And then in our hands, I'm not sure about in your experience, they can recur. So people always ask me like, well, what happens? Like, do you recur or not? Like you can try to put them on an acetylcysteine. Maybe it works, maybe it doesn't. I've had some where I just do it once and they go along their merry way and they're fine. I've had some that, I've had to do it a few times and they kind of recur every couple of years. Is that kind of been your experience too?
Totally. And I'd like to say that, well, if, the logic person in you would say, well, do they get better after you clean them the first time and then recur when it comes back? And if they did, that would mean it's the PSOM, right? But we see this waxing and waning kind of clinical presentation for Chiari malformation too. So it's just not as cut and dry in that. At the end of the day, we're just not great at treating Chiari malformation. I mean, you can either go the chronic steroids, chronic analgesics route, drugs like pregabalin and gabapentin, or you can do the skull reconstructive surgeries, which I've had a lot of success with, but also require a young animal and the understanding that you're not eliminating the clinical signs, you're just diminishing them. And so with the complexities of that, despite the dermatologic approach not being perfect, it's a lot less invasive and probably a lot less expensive than the management for the neuro stuff. But I agree with you. At the end of the day, from a likelihood of which one's causing the problem, I think it's more often the Chiari malformation.
Yeah. Do you get to use your cool 3D printer when you do like skull reconstruction?
I do. For those of you on the video right now, I have actually. Oh, did I just lose you?
Nope, you're good.
Okay. I dropped it.
It's okay.
I have a cat skull right here, actually, which is not a Combs dog. But yeah, we'll print out their skull and then we'll basically create a titanium mesh of what would be the ideal skull and then remove the back of their skull and place it in its stead.
So, so cool for you guys. For those of you who don't know, Dr. Wininger does a lot with 3D printing, actually has a company for it. So he likes to lecture and do stuff within certain CE conferences. It's wicked cool. So definitely check it out. Last couple questions about dogs. This is a big one. And I'm going to start off by saying, it's kind of like when I am on podcasts and people ask me my opinion about derm stuff. I'm like, here's my thought. I'm not trying to claim the opinion of all dermatologists out there, right? Because we're all different. But I always get asked this. So I'm going to pick your brain since I have you. That was
Yeah,
not meant to be a funny neuro pun.
I got you.
But the question is flea preventions in our epileptics. I get asked this all the time, right? Like, let's just say, let's put the scenario out there. It is truly a flea allergic dog. So it's not just like, oh, it'd be nice for them to be on flea control, but they come in to me and they're like bad infection, chewing their rump, like clearly need to be on flea prevention or their quality of life's impacted. But then they see you for managing epilepsy, whether they're on medications or not. What is your comfort level? What flea controls do you say that's okay? And again, I understand that everyone's a bit different with this.
Yeah, not only are neurologists a bit different about this, like they'll come to blows about this. I mean, when you're at the bar after all those lectures at ACVM Forum, I mean, don't bring up flea prevention. You'll see some fisticuffs, right? Basically, I think there's two sides to the story. On the one hand, epilepsy, seizures tend to be cyclical. They are often monthly or happen every 3 months. It's very common. We think it has to do with kind of hormonal variations and things like that. And so, what else happens monthly? Well, preventatives are often offered monthly, right? And so, I think it's very, very, very common for owners to create these false associations between seizures and the preventative. On the other hand, the isoxazolines, am I pronouncing that
Very
right?
good.
Thank you. And a lot of a lot of our common preventatives affect neurotransmitters, GABAergic tone, and things like that. So it stands to reason that they could have an effect on seizures and seizure management. My experience is that if you have a dog that's having seizures and the owner is making an association between the preventative and the seizures, try changing to a different preventative. And I think most of my colleagues would agree that if you have a preventative that induces seizures, it often doesn't if you go to a different preventative. So that's kind of my move.
It's not going to be like a catch-all, like you just can't do any flea med. It's like, well, if we're even worried, even though we can't prove it necessarily, right? Like we're not going to just keep giving it if we're worried about it, that they had a reaction to one isoxazoline. Do we just rule out all isoxazolines and move to something else?
Exactly.
Because I've heard everything. I have heard this one's fine. I have heard topical, not oral, and I don't get that one. So I've heard just don't do it at all. So when I'm managing an allergic dog, if I'm not convinced the flea prevention is an issue, like where I live, flea prevention in general is important. But if I don't think flea allergy dermatitis is a big portion of their disease process, I'm not going to keep pushing it just to feel good about myself. But there are dogs that come in and I'm like, man, the way that they're chewing at their rump's probably not super good for their activity level either, right? Because they're so crazy uncomfortable and they're getting crazy MRSPs. So it's a tough
Right.
one.
Yeah. Yeah. I don't know that there's a right way around it, but I think that I think that the value of those preventatives is too high, especially when you start getting into things like heartworm as well. The value of them is too high to just ignore it and say, don't use them as a blanket statement in cases of epilepsy.
Yeah, and I think in general, right, there's so many factors. Like you said, I'm never a fan of blanket statements. You have to look at what is the risk factor, right? Like where do you live? How big of an issue are parasites? Because if we avoid something, to your point, like, I knew you in Missouri, so like I trained in the Midwest, so it's like heartworm's a very big deal, and you don't want to avoid it to the point they get heartworm positive, and then that is the demise of the patient, right? Like that's problematic.
Right.
But if you live somewhere where like maybe parasites are not a big deal, and the pet's just chewing their paws and not showing signs of flea bite hypersensitivity, like maybe we are okay with that and the risk benefit factor is not there. So it
Sure.
doesn't sound like you just take out a class. Like you're not like, you just can't do this. It's more situational dependent on that particular patient.
That's right.
Perfect. Last question about dogs that I have for you, and it's an interesting one. Have you seen skin disease such as like being really itchy to a certain area or acrolick? Sometimes I get asked this if they have a focal acrolick. See that association with like neurologic pain? Have you ever identified that? I get asked that for some of my acrolick dogs. Like, well, but if they also, I think they might have neurologic pain, so maybe they're uncomfortable. Is that something that you have recognized in the clinic?
That's tough. We certainly see neuropathic pain in dogs that have had spinal disease. Particularly in the low lumbar spine, dogs will start chewing at their feet or chewing at their rump. But if it's been associated with like an acrolick formation, I'm not really sure.
Yeah,
I
not
thought you were going to ask me about like dermatomyositis or something
listen,
like
that
that.
was on my list depending on time. We can jump in. I know
Okay,
you love the muscle, so we certainly
I
can jump
do.
into that real quick. That's no problem. But yeah, I think to your point, it's not very common, right? Like so sometimes we get asked that. Now with arthritis different. I've
Hmm.
definitely seen acrolick granulomas. Like we usually see it for allergies, but I have seen it where they have patients that just go to one like the carpus and that is it. Like their allergies are great except for that. I will send them to get x-rayed by their primary vet and like these like really terrible arthritis in that joint. So acrolick just means we are attacking an area either because of itch, pain, some discomfort, but it doesn't seem like it's very common with neurologic disease.
I don't think so. I mean, we see the dermatologic diseases we tend to see as a consequence of neurologic disease in the periphery are going to be things like moist dermatitis for the down patient or ulceration of the limbs because the sensation to those limbs is diminished. I think so often when we think about the down dachshund, we're always thinking about, is he moving his legs? Is he moving his legs? Without a recognition that if you don't feel something, you're not going to protect it in the normal way. Like right now, I'm talking to you and I'm shifting around in my chair because I don't want my butt to necrose, you know? And if an animal doesn't have knowledge of that, then they're going to actually develop sores. And I think that's often forgotten.
Yeah, that's a really good point. So, like, I remember being a student on neuro and like urine scald, things like that seem so simple, but like you said, they can't control their bladder / they don't really notice it's uncomfortable, if that's happening.
Right.
Okay, Dr. Wininger, let's end this episode talking about dermatomyositis. I hardly ever see it, but it is a crossover. So what you got?
I've seen it once, and I just get excited because I love Shelties because my childhood dog was a Sheltie, so that's kind of all I know about it. It causes muscle problems and face dermatitis.
Yeah. So is it? It's usually seen in young. That's it. That's why you wanted me to ask you.
No,
You don't even know.
I know more about it. I just didn't want to bore you with muscle diseases and stuff like that.
So
But,
essentially,
yeah.
if you see like a Sheltie or a Collie who's younger, and they look like they have muscle wasting / they look like they have ischemic dermatopathy on my end. So they usually look like they have really bad ischemic dermatopathy, but it's pretty hallmark in those breeds, right? Like you can biopsy them, of course, and you want to get like skin muscle, but it's not very common. But just shout out to know that it is a disease that exists. And if you guys love it so much, I'll have Fred back on and we can dive all into it. But I think I've seen like one case.
Yeah, everybody loves a breed flashcard, though, right?
Yeah.
And if I say Sheltie, I mean, what diseases are you thinking of outside of dermatomyositis?
Yeah.
So every breed's got to have something.
Yeah, that's how I feel in our world about St. Bernards. They get a nasal planum disease called it's an arteritis, nasal septal arteritis. There's a bunch of names, but I'm like, how often do you hear that a St. Bernard is the predisposed breed? So if it's a St. Bernard and they've got linear ulceration on their philtrum, I'm like, that's it. Like, you've got it. Perfect.
And the worst cases of epilepsy. I mean, to me, they rival Australian Shepherds. They are brutal
St.
to
Bernards?
treat. Yeah.
Oh,
Yeah.
okay. Two things for those St.
Two
Bernards.
things. There you go.
Well, Dr. Wininger, I just want to thank you for giving your time today to be on the Derm Vet podcast. Connie talking all about dogs, some of the overlap we have. I think you and I could probably talk for hours. We're so passionate about our specialties. But I just appreciate your time talking about dogs today.
Same. Thanks for having me on. I appreciate it.